Assalamu alaikum. I'm thankful for the scientific committee for assigning me to this very easy subject. And I'm pretty sure also most of the attendees are aware, so bear with me about how to approach eosinophilia. This is actually a very, it's kind of an old presentation that I did back in 2018. And when I tried to update it, I found that I only updated the first slide. So nothing much actually has changed in the area of eosinophilia, or the progression is very slow in finding new medications or new approaches. So we're still doing the same as we did before, but more likely we would like to involve a lot of biologics in this area. So moving forward. My dear, any keyboard? طيب. So for the objectives today, inshallah, we're going to be focusing more on hypereosinophilic syndrome, but at the beginning, inshallah, I'll try in a short period just to explain a little bit of basic sciences and the eosinophil itself, as it's one of the most fascinated cell we can see under the microscope. So definitely we know that it has a major function in parasitic infections, and as well as in modulating the innate and also the adaptive immune system. Tissue hemostasis, we even started to know that actually it plays a role in even forming blood clots and DVTs. So patients with hypereosinophilic syndromes are more prone actually to develop DVTs as well. Under the microscope, this is an electron microscopy showing the fascinated al-khalaya al-zahriya, the eosinophilic cells, and the major part of it, the granules that actually forms inside them containing the eotoxins that are responsible for the either killing or even asking more chemotaxis, more cells to come and cause more fibrosis into that area of the inflammation. So whenever they are activated, those eosinophils, which we want them to be activated whenever there is a need, otherwise we want them to stay dormant. They are fascinated killers, so they direct cytotoxic, and also, as we mentioned, asking more cells to migrate into the tissues, causing more inflammation and hence more fibrosis. So 3 phases. I'll try to skip going back to going directly to the summary, which this picture actually. So you have maturation of the bone marrow, and the maturation is morely modulated by interleukin 5, which is going to be the more directed, individualized therapy you would like to go through, or targeted approach. The migration then from the bone marrow, when it's mature, then to the peripheral blood is also modulated by interleukin 5. And then those mature cells use the axis of interleukin 13 and 4, which there is a targeted drug also to that area, migrating from the blood to the tissues where they stay dormant. Whenever there is need, interleukin 5 and 33 plays a major role. So this is why anti-interleukin 5, inshallah, will be talking more as a serious or a fascinated drug actually into stopping this activation whenever it's not needed. Interleukin 5, 33, 4, 13, those are the mere biologic therapies that we would like to target for those eosinophils. Hypereosinophilia has multiple I should say, terminologies that have been used. Since going back to 2010, multiple classification system has been developed by the American group, Italian group, WHO, and it's kind of, most of them are focusing around the same, or trying to, flying around the same point, which will be summarized in shortly. But then moving to labeling someone as a hypereosinophilic syndrome, You just don't need to rule out the secondary cause, but also other primary malignant hematological disorder that has an association with hypereosinophilia. So we're going to touch slowly on the classification scheme and the diagnostic criteria and the presenting symptom and the secondary causes later on. So with hypereosinophilic syndrome, we have either the circulating blood cells, which is 1.5, and then also the tissue eosinophilia, where you need biopsy. The NTOC for tissue, you just need a biopsy from anywhere that you think that has been affected by eosinophilia itself. So to say something has hypereosinophilic syndrome or a person, we need absolute eosinophilic count and evidence of end organ damage, and you have ruled out secondary causes as well. Common presenting symptoms, we always think about the skin as the most common presenting symptoms in different forms, especially pruritus. Lungs can be affected, GI tract, most likely the upper part, less likely the lower part. And the musculoskeletal system, there is a syndrome called myalgia, eosinophilic syndrome as well, so multiple classification. Heart, neurological, which is commonly presented if actually left untreated, and also hematological with DVT, as we mentioned earlier. So treating is critical. Why? Because eventually these cases will, if left untreated, 20% will develop cardiac symptoms or neurological symptoms. So it's better to capture them early, treat it, lower the burden of the disease. So this is one of the ways that has been for hypereosinophilic syndrome classified. So this is back from 2010, and there are new classification, the Valent classification or the Italian group classification, but again, they are all flying around the same point. So familial cause, going from the far right, familial causes, there are families who just present with hypereosinophilia. Undefined, when basically you don't know the cause, or sometimes it's episodic, that the patient you see 2 years ago had eosinophilia and then resolved, and then again he has eosinophilia again. And you keep doing the secondary workup again and again, and you don't find the cause. Associated, especially in cases of Churg-Strauss or the eosinophilic granulomatosis polyangiitis, is inflammatory bowel disease. The overlap when it's actually specified to a certain organ itself. And then we talk heavily about the lymphocytic and the myeloproliferative as hematologists, because that's when our role come in with fancy tests, making sure those lymphocytics are clonal or not, and even with the myeloproliferative, if they are clones that are known or not. So for the myeloproliferative ones, we tend to do the PDGFR alpha and beta, and also the FGFR1. And I do believe in 2026, relying only on a single one is not efficient or sufficient, I should say. We tend to do it, the PDGFR1, and then stop. That's because sometimes what are the tools available for us to do for hypereosinophilia, but I do believe the panel should include all the three. And then that's when you figure out if it's clonal or not. If you couldn't find the clone, then you do the JAK2 and the BCR-ABL1 or ABL1 groups all together. Here actually comes the value and the significance of doing or finding elevated serum B12 levels and also the tryptase. For the lymphocytic one, it's a syndrome. It's a there are multiple disorders that actually falls into it. And here, when you need flow cytometry, you need the immunohistochemistry on the biopsies that you take, whether from the skin, the GI, the heart, whatsoever. And here, actually, even where the Gleach syndrome, where you have the patient with eosinophilia coming with angioedema multiple times, tryptase negative, you prefer to think about the Gleach syndrome here as well. And then the overlap, where you a syndrome that is caused or eosinophilia confined to a certain organ, but how about if that organ was the blood vessels? So like Churg-Strauss or the eosinophilic granulomatosis polyangiitis. So the blood vessels will be inflamed all over, the whole body is going to be affected. Here also the most commonly one that we see, which is the eosinophilic esophagitis or a bronchial asthma that you cannot confirm. You see the pathognomic tracheal in the esophagus. And then the undefined, which constitute major part in the retrospective studies and the registries where you don't know what's the cause of the hypereosinophilic syndrome. So the secondary causes, an exhaustive list that you sit down in the clinic, you are referred with a patient with absolute eosinophilic count, which is high, and you try just to work your way through all of them together. Most of the time, it is actually going to be one of those three. So you figure out with the history if there is a drug hypersensitivity. Even like Pantoloc or pantoprazole can cause elevation in eosinophils. And you evaluate for parasitic infections, relying heavily on what's your serology test doing. For example, strongyloides, how much accurate the test you have or the tool in your lab, and even asking the lab to perform ovam parasites into karama on the stool. So, and then the lab just disagrees because the patient is not immunodeficient. We're not going to do ovam parasite. So you try to convince the lab also to do those tests. And you also evaluate for neoplasm, especially when it's a severe eosinophilia. Most of the time, it is associated with malignancy like lung cancer or breast cancer, as we've seen multiple times. So you generally evaluate with the history first, and then because there is a part of it is a familial history of it just runs in their family. But you go with a CBC with differential, and I would like to stop here mentioning 3 points with the CBC. I think in 2026, again, we should not order CBC without differential. I don't know why each lab is still doing this without a differential, because then you will never find out if it's actually hypereosinophilia. The second one is basically those labs that report percentages rather than absolute eosinophilic count. But what's good about it, they are still labeled, they put the letter H or critical or something, asking the physician actually to do the absolute eosinophilic count with his own calculator. And then the third one is the project I did with medical students was basically asking them, how about we do a QI project in our own lab, asking to put a flag on whenever there is a hypereosinophilia, just to consult internal medicine, sorry, or consult pediatric, general pediatric, or consult hematology, just for the hematologist to keep a follow-up. Because actually the definition of eosinophilia is not only finding one reading of 1.5, but if it's persistence over 1 month as well. So you need a follow-up for your patient as well, just to make sure the patient is having persistent hypereosinophilia, necessitating workup and test from your own part. You would like to do a peripheral smear looking at if there is an associated malignancy, sorry, or hypereosinophilia. Flow cytometry to figure out the markers. Ovum parasites, the ANCA for the Shirk-Strauss, and the serum IgE, strongyloid, ESR, CRP, absolute neutrophilic, anti-nuclear antibodies, the B12, the tryptase, the HIV serologies. Those are all important to be done when you evaluate a patient for hypereosinophilia. And I would like just also to say, in a governmental hospital, maybe it's easy. In a private hospital, acquiring approval from the insurance, you have to list all these, and you will be lucky if you get them all. Then if you think my patient is having an organ involvement, it's better to figure out non-invasively how to do those evaluations with the troponin, with the serial ECGs and echo, pulmonary function test, urinalysis, according to the organ you're targeting. Then if you think I might have an end organ involvement, you go through an MRI, biopsies, anywhere. Even biopsies actually do have certain criteria. For example, in the GI, for the esophagus, you have to take 6 random biopsies from different places. Then you can confirm if the patient is having eosinophilic esophagitis, for example. So a single biopsy is not enough. Focusing here on where to get the sample for the molecular test for PDHFR, alpha, beta, and FGFR. Should it be the bone marrow, or can it be done from the peripheral blood? And also that perspective, you do it if you have a huge enough eosinophils in the peripheral blood, then you can do it from the peripheral blood. But then you're still gonna miss probably an associated hematological malignancy from the bone marrow itself. So ideally, it's better to do a bone marrow for hypereosinophilia. It sounds scary for a patient who is young. You'd like just to do a bone marrow, but it's at least one time just to rule out a nidus for hematological malignancy that can be associated with hypereosinophilia. So to summarize, you need a tissue or a blood sample to start up the test. When you evaluate, you get that evaluation or that referral usually from a pulmonologist, from a GI, or even from our colleagues in allergy and immunology as well. So treating hypereosinophilic syndrome after ruling out secondary causes. Sometimes you don't have the chance to do all that test. Your patient is going through an acute event, so you just need to pull the gun and treat your patient. So basically, you'd like to start with high-dose steroids. Sometimes it's kind of like prednisone, 1 milligram per kg per day. But sometimes you're treating a patient in the intensive care unit. You have to give intravenous doses of steroids. You can use, and there are certain factors that actually tell you the patient with hypereosinophilic syndrome is actually going to be severe enough to be treated. So having hepatosplenomegaly, age, hemoglobin less than 10, or evidence of cardiac involvement, elevation in tryptase or B12, any of these factors, a single one, will push your patient to high mortality. So pulling the gun, treating the patient early, and then following your patient up is actually important to keep treating your patients and inshallah prolonging his life. So figuring out the molecular pattern, so PDGFR1 or FGFR1 will help you also selecting the treatment for your patient. And all the three has to be done, because even if you did one of them and it's negative, for example, the PDGFR1, you're giving your patient imatinib as a first line that is going to help your patient. The usual dose is 100 milligram daily, but for PDGFRB, the best initial dose is 400, then maintaining a patient on 100. Second line also for TKIs, more commonly known dasatinib and nilotinib, the data behind it is very scarce. This is why I couldn't bring it up. If it's PDGFR negative, you think about hydroxyurea, interferon alpha, and sometimes rarely use methotrexate or cyclosporin. Then we think about targeted approaches, how to directly minimize side effects of medications that we might be giving. Nucala or mepolizumab is the most commonly drug that is being used, and the patient are referred to us to figure out if this is the medication we use or not. But there are actually other options of therapy that are actually going on, depending on the targeted approach you would like. So mepolizumab is the one that binds to interleukin-5, and it is, according to phase 3 clinical trials, approved. And those can be as easy as 100, but if you're dealing with hypereosinophilic syndrome, the lymphocyte subtype or the lymphocyte, so you need to increase the dose to 300 rather than lowering it. Benralizumab is also being still under investigation to be approved, which doesn't bind to interleukin-5, but binds to the relative subunits that actually activates the interleukin-5. And there are the other medication, the dipimukimab, which is given once every 6 months. So you save your patient the option of getting those medications on weekly or sometimes maintenance on a monthly basis. And then the dupilumab, which is when you can add it on top of anti-interleukin-5 because it stops the tissue activation of the eosinophils. So if you see the patient is having additional tissue symptoms, you can add dupilumab on top of anti-interleukin-5. And then there are the others that our colleagues in respirology and immunology, they use commonly for asthma. So you use omalizumab, alimtuzumab. Maybe we and the neurologists are the only people who are using it. And then lirentelimab, which is not yet approved. Jakavi is being used, sorafenib and other subunits are all under investigation. But there are plethora, but nothing has yet beaten mepolizumab. So in hypereosinophilic syndrome, it significantly decreased the risk for flares for hypereosinophilia, and in eosinophilic glandulomatous with polyangiitis, Churg-Strauss, it led to better remission in patients. But what is really capturing the eye in those trials, that even if you left the patient untreated with placebo, some of them would actually reach to remission, which brings us back. Did you diagnose your patient very well? Did you risk stratify the patient very well? Which is the more work we have to do when we diagnose a patient with his. This is the phase 2 with the benralizumab. It also reduced 50% the absolute eosinophilic count in more than 90% of patients who were involved, but still the sample size was low, which of 20 patients involved in this trial. But reminding you, it's a phase 2. So is it easy to give anti-interleukin 5? Definitely. Nothing comes without attacks. So the nasopharyngitis, injection site reactions, which the patient, they never like it, especially if you're giving this medication on weekly basis or monthly basis. They always try to avoid it, especially if you're trying to deal with a teenager. They always try to avoid it, as I see commonly in my clinic. It actually even cause a rebound nasopharyngitis, and the patient will say, my symptoms were not relieved. But basically, this is just a side effect of the MIPO rather than eosinophilia itself. Probably I came to the tail end of my presentation. So again, how to approach it at presentation: you do your due diligence with history and physical examination. The workup we mentioned, you probably want to start non-invasively, then move to the invasive parts. If you couldn't find out the cause, sometimes you have just to pull the gun and treat the patient with steroids, and then look at, later on down the road, and then think of what type of HIS I am dealing with. Is it a lymphoid, idiopathic, overlap, myeloid? And accordingly, you want to pick up your choices of therapy rather than just give everyone mepolizumab. So prompt treatment should be individualized, and the new emerging therapies are coming on, but they're not coming fast. So it becomes very slow that changing the guidelines into the area of eosinophilia. Shukran jazeelan.